Hello everyone, welcome to HIM 216. We're going to begin chapter 9, which is the last chapter in this book that we'll cover this semester. Next semester we'll use this same book and we'll actually begin with chapter 26. That's the reimbursement methodology chapter, so absolutely don't plan to do anything with your book, your textbook, or your workbook. So in your textbook, open to pages 180 and 181. And while this is chapter 9 in your book, it's actually chapter 10 in ICD-10. We're studying infectious and parasitic diseases, and this is a very commonly coded from chapter. Look at the abbreviations and the acronyms, and I'll also point out, I come back and look at these often. I want to add, there's from the respiratory chapter, RSV, which is actually on page 407. So when I was going over this chapter, I actually noticed that, and I can never remember what RSV stands for. They came out with that after my kids were past the point in time when they would ever have it. But on 407, it tells you this RSV, respiratory syncytial virus, something kids now commonly get. I'm sure they commonly got it then, they just didn't have a term for it. But that's on page 407. Now, to start off with, we're on the bottom of page 181. And one of the first guidelines that we're going to talk about is HIV, human immunodeficiency virus. I think we've probably all heard of HIV. What most people don't realize is that you can actually be a carrier of the virus without actually manifesting the disease. So you can be HIV positive or you can have AIDS. And the guidelines are very specific. First of all, you can only code confirmed cases. And confirmed means that the provider, the physician, says, this patient is HIV positive. This patient has AIDS. Or they may tell you that the patient has an AIDS-defining illness. There are certain opportunistic infections that if a patient is HIV positive and they develop one of those opportunistic infections, they are considered to have AIDS. Our immune system would normally suppress those conditions, but in patients who are HIV positive, they do not. Now, I will also say that a person can have some, like candidiasis, which our body usually suppresses. You can have another autoimmune disease that does not allow your immune system to suppress. So you can't assume that someone who maybe has candidiasis is HIV positive. You do need the documentation that the patient is HIV positive, and then when you have documentation of one of these opportunistic diseases in those patients, then they have AIDS. So if the physician tells you that the patient's HIV positive, or that they have AIDS, or they have an AIDS-defining illness, you code from that. You can code from that. You don't have to have the results of the actual lab testing in the chart. There's another very important guideline that you need to understand. Once a patient is HIV positive, that code is actually Z21. And if we go to human and then immunodeficiency virus, HIV disease or infection, we will find asymptomatic status, and that's when they just have had a positive HIV lab test. That code is Z21, HIV positive NOS. Now, if a patient progresses from being an asymptomatic status, just testing positive for HIV, to actually having AIDS, the code for AIDS is B20. Once they have AIDS, they always have AIDS. It does not matter if they are treated with medication and they become asymptomatic. Once someone is coded as B20, they are always B20, and you will never code them as Z21 again. So that's very important to understand. Once they have developed the disease, they are always coded with the disease. Now, something that's also very important is that if a patient comes in with, if they have AIDS and they're coming in with an AIDS-related illness, the code B20 is always coded first. So if I have a patient coming in with pneumocystis carinii pneumonia and they have AIDS, and the condition determined to have occasioned the admission is the pneumocystis carinii pneumonia, the B20 will be listed as the principal diagnosis code because that is what the guidelines tell us. Now, it's also very important to know that if a patient comes in with a condition unrelated to that AIDS, let's say that a patient who's HIV, who has AIDS, is in a car accident and they fracture a femur, that fractured femur will be the principal diagnosis code because it is unrelated to the AIDS. Look on the top of page 182, and you'll see an example. A patient came in for treatment of Kaposi sarcoma of the skin. The patient's HIV has been symptomatic for the past year. Well, it may have been symptomatic for the past year, but Kaposi sarcoma is an AIDS-defining illness. They are now coded as having AIDS. They're coded with B20. And then the Kaposi sarcoma is coded as a secondary diagnosis. If we read this, we would think, oh, well, okay, the Kaposi's is actually the principal diagnosis. It meets the definition, but it's not going to be the principal diagnosis because the guidelines tell us that B20, AIDS, will be the principal diagnosis. If you look at the second example, this patient came in, they had a traumatic closed fracture of the left femur. They also have AIDS. You can see that this code S72, that is the code for the fractured femur. And if I go to that category, S72, come on, let's go. Oh, I don't know if my internet is slow or if it is 3M. Okay, S72, fracture of femur. A code from this category is going to be the principal diagnosis. Then we're going to have a code for the AIDS, B20. Then we will have an external cause code for that accident. Now, there are some scenarios that relate to newly diagnosed patients. And if a patient is newly diagnosed as being HIV positive, they are Z21. And it doesn't matter when you're using Z21, it doesn't matter whether they're newly diagnosed or whether they're just HIV positive. And actually, there are many people who are HIV positive and they never manifest the disease. I was watching a TV show one time and researchers have found that if you are of European descent from ancestors who survived the bubonic plagues, then you have somewhat of an immunity to HIV. But if you are African or Asian or South American and your ancestors were not exposed to the plagues, then you do not have any immunity. But for some reason, Northern Europeans who survived about 3 bouts of the plague seem to have some immunity to HIV. But once you're positive for it, it doesn't matter whether you're newly diagnosed or throughout the course of your life. You will always be Z21. There is inconclusive serology, and there is a code for that. R75. And in the index, if we go to human and then immunodeficiency viral status, you will see, we should find laboratory evidence, R75. This doesn't say inconclusive laboratory evidence. It says laboratory evidence, R75. Let's try to look this up by putting well, okay, so if we go to syndrome immunodeficiency, it will tell us to see human immunodeficiency virus. So there's not a in the index, there's not a subterm that includes inconclusive. So laboratory evidence is what we would have to choose from the index to take us to the code for the inconclusive laboratory evidence. And then on page 182, if you look at F, it tells us that if a patient has any known prior diagnosis of an HIV-related illness, they have to be coded to B20, and that once you're a B20, you will always be a B20. If you're coded a B20, you cannot use the codes R75 or Z21 with B20. So it's almost like a progression, like an algorithm. You know, you can have inconclusive serology that's R75. If that serology becomes HIV positive, then you are no longer R75, you are Z21. And if you actually develop full-blown AIDS, you will no longer be Z21, you will be B20. So it is absolutely a progression, and you do not go back. Now, if a patient has human immunodeficiency, if they are HIV positive, let me go to Z21, or they have AIDS and they are pregnant, you first are going to code a code from the OB chapter, which is chapter 15. And OB codes take precedence over everything unless the condition is totally not going to affect the pregnancy, and we assume that it will unless the physician tells us differently. So that is a chapter-specific guideline for chapter 15, and so it even supersedes this AIDS guideline, and we'll look at this more when we're in that chapter. If I would go to pregnancy complicated by human immunodeficiency virus, it takes me to this code O98.71. And then, of course, we would choose the right code based on the trimester of the patient. And you'll see that this particular category, it does not matter whether they're HIV positive or whether they have full-blown AIDS. We have an instructional note that tells us to use an additional code to identify the type of disease. So while this code says, oh, my OB patient has HIV, it doesn't tell me whether they're HIV positive or whether they have full-blown AIDS, and so I have to add the very specific HIV code actually indicating what the status of that patient is. And this is something that you'll see often in coding is we'll have a code that says, oh, this patient has something else, but as it doesn't tell us the specificity of the something else, and so we have to go and code that something else. And this is an example of that. And if you look on the top of page 183, this is a patient who's 20 weeks pregnant. They come in for treatment of esophageal candidiasis due to AIDS. So in this particular example, our patient is 20 weeks pregnant, and that is actually the second trimester, and we will study that when we get to that chapter. And so that OB code is first. Then we have the code for B21, B20 to say that they have AIDS. Then we'll actually have the code for the esophageal candidiasis, and then we have a code indicating that the patient is 20 weeks pregnant. And we'll go over those codes, pregnancy codes, in detail next semester when we are in chapter 15. You can see in the next example, this is a patient, an OB patient who's 39 weeks pregnant, and she comes in and has twins. She's been asymptomatic during her entire pregnancy. And what code? And so for this patient, the fact that she is delivering twins, we will use that delivery, the multiple gestation pregnancy code. Then we'll have the code for the fact that she has a pregnancy complicated by HIV. Then we will have the Z21 indicating that she is HIV positive. Z37.2 is an outcome of delivery code. Z3A.39 is a week's gestation code. And then 10E0XZZ is actually the code for the procedure code for the delivery. Now, also on page 183, we have a patient who has high-risk homosexual behavior. They are coming in for HIV, for an HIV screening. And when patients are coming in to determine their HIV status, the code that we use is an encounter code. If we do encounter for screening, it tells us to go see screening. And then if we go to screening and human immunodeficiency virus, we will find this code Z11.4, and it's a code specifically for HIV screening. And then they have also used this code Z72.52, and this is a code for high-risk homosexual behavior. That is probably not a code, so we can see high-risk sexual behavior, behavioral, homosexual. Unless the provider specifically documented that, you should not assume that just because someone who comes in and says that they are homosexual and they want to be tested for HIV, that they are engaging in high-risk behavior. So you would definitely want the provider to document that before you coded it. In this next example on page 183, the patient comes in for tests that are negative, and they are counseled regarding HIV prevention. And we can go counseling for human immunodeficiency virus Z71.7. And then in this fifth example on 183, the patient returns for test results that are positive and they are asymptomatic. So they're also given counseling for HIV. But in this case, because the test results are back, Z21 becomes the first listed diagnosis code. Now, I want you to turn to page 199 in your book. Now that we have these guidelines for HIV fresh on your mind. And there are some things about HIV that you need to understand. When when patients have HIV, their immune system is affected. And when that immune system is affected, when it's suppressed, it allows things that our bodies normally fight off every day to make us sick. And it typically affects our white blood cells. And the specific cells that it typically impacts are the CD4 cells. So a normal CD4 is between 500 and 1600. And they actually use percentages when they're determining AIDS. And if a CD4 count goes below 350 cells, then a patient is considered to be at risk for developing herpes, TB, Kaposi sarcoma, non-Hodgkin's lymphoma, and if the count goes below 50, they can develop Mycobacterium avium or cytomegalovirus. AIDS is treated with drugs that are called HAART, highly active antiretroviral therapy. Patients can be given these on a prophylactic basis to prevent infections. Some patients' CD4 count will rebound so that it becomes above 200. And there's a term that they use for the lowest documented CD4 count that a patient has had, and it's called a nadir, N-A-D-I-R. So if a patient's nadir is 150, it means that the lowest level that their CD4 count has ever been is 150. And this can change as they're treated or as their disease progresses. But once they develop AIDS, they're coded B20, and that never changes. So if we look at this example on the bottom of page 199, this patient came in with Kaposi's, and we would list B20 as the first listed code, and then the C46.1 for the Kaposi's. Now turn to page 200. And at the top of page 200 in box 9.1 is a list of AIDS-defining conditions. And this tells you that the CDC considers patients to have AIDS if their CD4 T-cell counts below 200, or if the patient has one of the following defining illnesses. Now, this is in a patient who has been HIV positive. And you can see these conditions that are listed, and you need to read these carefully. These, to me, are note card type of conditions. And I want you to notice, for instance, Mycobacterium tuberculosis. And on your homework, they're going to say, oh, this patient has this condition, how do you code it? You're going to come back to this list and see if the condition's on this list. That's why you need to read it carefully. Some are very obvious. Candidiasis esophageal, invasive cervical cancer, not just any cervical cancer, but invasive cervical cancer. Then you're going to come back and see, you'll see Kaposi sarcoma, lymphoma, Burkitt's. So Burkitt's lymphoma is an AIDS-defining illness. Then you have the Mycobacterium avium complex, Mycobacterium tuberculosis, Pneumocystis carinii pneumonia, recurrent pneumonia. If you have an HIV positive patient who is having recurrent pneumonia, and the physician documents recurrent pneumonia, they have developed AIDS. They're not Z21 anymore, they're a B20. So go through those carefully. Now, and then we have AIDS and pregnancies and encounters for HIV testing. We've gone over those in the guidelines. For this lecture, exercise 9.5 I want you to answer question 1, question 3, and question 5. So those are the questions for this lecture. Then I want you to come back to the guidelines on page 183. B on this page talks about infectious agents as a cause of diseases classified to other chapters. These codes begin with a B, obviously. We're coding in Chapter 1, certain infectious and parasitic diseases. The range of codes for this chapter are A00 through B99. As you look at this chapter, there is an excludes one note, localized infections. Typically, these are of the skin. And then the excludes 2, and of course, OB patients are listed here as well. But if we go down, and we want to look at these codes for diseases classified elsewhere. Okay, so in Chapter 1, bacterial and viral infectious agents. If we go to this particular section, we will see that this includes the staph, strep, and enterococcus as the cause of disease classified elsewhere, other bacterial agents as a cause of disease classified elsewhere, and viral agents. So if there's a note here that these are supplemental or additional codes. That's your clue that these codes are not going to be a first listed or principal diagnosis code. If we go into these categories, clearly this category says as cause of disease classified elsewhere, and it lists all the staph, strep, and enterococcal conditions. If we go down to B96, again, bacterial agents as a cause of disease classified elsewhere. This is where we find like the Klebsiella pneumoniae, E. coli, and if we go to infection, and then look at Escherichia coli, you can see that there is a code just for this organism, A49.8. But if I have a UTI that's due to Escherichia coli, I'm going to use the code B96.20 because the Escherichia coli is causing a disease in another body system. Now, there are some combination codes. There are some pneumonia. And we'll study these when we're in this chapter. Pneumonia due to Escherichia coli. We do not code then a B code for this because this code very specifically includes the organism. So there are some combination codes that include those organisms and they are not coded separately. But if those organisms are not included in the description of your combination code, then you have to add a code for them. If we look at candidiasis, and we have a patient that has a urinary tract infection due to candidiasis. We have other urogenital candidiasis. We do not then add a code for candidiasis B37.9 because we have this combination code specifically that tells us we have candidiasis of a urogenital site. There are also organisms that are resistant to antibiotics, and these have a code in category Z16. So these are from the factors influencing health status, and this is a specific category of resistant to antimicrobial drugs. And if we go to resistance, organism to drug, and then you can see what the you can see the listing of the drugs that the patient is resistant to. So in the example we have, patients admitted to the hospital with pneumonia due to MRSA. If I go to pneumonia, actually, if I go to pneumonia, Staphylococcal aureus methicillin resistant, then I will get the code J15.212. Okay, that is going to conclude this first lecture for Chapter 9.